So Mike's talk will be really talking about the pipeline for deaf and hard of hearing scientists in STEM. And just to give you a little background on Mike, Dr. McKee is a family physician with clinical and research experience in disability health. He's born deaf and has a cochlear implant. And as a deaf physician, he's very interested in advocating for the rights of deaf and hard of hearing patients to obtain equitable health care, and that includes accessible communication. His own research focuses on health disparities for individuals with various forms of disability, including health information access, health literacy, and telemedicine applications. So there are many things that many of us in this room are very much interested in and concerned about. He graduated from the University of Florida College of Medicine and then did his family medicine training at the University of South Carolina, and then did a preventive cardiology fellowship at the University of Rochester. He's currently an associate professor in family medicine at the University of Michigan, Michigan Medicine. He serves on the board of the Association of Medical Professionals with Hearing Loss, and he's also an appointed member of the Roundtable on Health Literacy of the National Academy of Sciences, Engineering, and Medicine. In Michigan, he directs the M Disability and Deaf Health Clinic and is co-director for the Center for Disability Health and Wellness. And then that probably keeps him pretty busy, but in his spare time, he also enjoys hiking, kayaking, gardening, and beekeeping. So he has a broad range of activities. And it's a great pleasure and honor to be able to welcome Mike and to deliver our third and final keynote address of the day. Mike, thank you.
I unfortunately was not able to come to Rochester for the conference. I was looking forward to seeing everyone there, and I'm disappointed to not be able to make it, but I am honored to be invited as the keynote speaker and to present about this topic, which is very near and dear to my heart. Today I'll be talking about potential ways and strategies to increase the number of deaf and hard of hearing scientists and medical doctors, healthcare providers, and clinical researchers. So let me start with this. Why us? Many people may struggle with this idea of why is it important to include deaf and hard of hearing people. There are negative perceptions and isms. Autism, for example. So people grow up with these negative perceptions of themselves. But in fact, deaf and hard of hearing people have a lot to offer and a lot to contribute, especially in areas like healthcare, medicine, research, and I'll talk more about this. It's very important to support a more positive view of deafness and our deaf identities. For those of us who grew up with a negative perception of deaf people, I will suggest that we can shift that perception to be more positive. And so for the title of this talk mentions, I will talk about some of the gaps that we can address, and then I'll also give some examples of strategies that have worked so far to address those gaps. I know many deaf people do not identify as disabled, but instead as a cultural and linguistic minority, and I do respect that and recognize that. But deaf people learn strategies of coping, strategies of overcoming barriers. That's part of our lives as deaf people. And so some of those strategies that work for people with disabilities also work for people who are deaf. This is from some of my early training days. I focused on deaf people only, but now in my clinic work, I've expanded to work with other people with disabilities as well. And the reason for that is that communication access, communication strategies, ways of improving effective communication that work for deaf people often also work for disabled people as well. There are many similar experiences between our two groups. And the things that work for deaf people, we should contribute that back to working with disabled people as well. Now, people with disabilities now account for 1 out of 4 people in the United States. It's not a small group. Disability impacts all of us. There are people you see every day, people in hospitals, in clinics, people I visit every day, people who are included in research, and unfortunately many people who are excluded from research as well. And so we can take advantage of the skills that are offered by that group and improve services for everybody by improving services for people with disabilities and people who are deaf. Instead of working in silos, so the idea that deaf people only do research related to deaf people, wheelchair users only do research or support other wheelchair users. But that also marginalizes people who are members of both communities, such as the deafblind community. So instead, I suggest that it would be better for all of us to work together and support each other. Now let me shift to talking more about specifically deaf and hard of hearing people. So over the past 10 years, there have been several publications that have found many gaps. There are many ways that healthcare is not effective and inaccessible for people who are deaf. There are many ways that communication fails in healthcare settings. So people who are deaf or hard of hearing, or people who have hearing loss, have identified some major barriers such as communication. And the communication barriers are not the patient's fault, but are because the systems are not complying with the ADA requirements that they should to provide effective access to communication. And it's important for all of us to be involved in solving that problem and showing that it's not right and that everyone deserves equal access to communication. In the United States, 17% of people have some sort of hearing loss, some of whom identify as being deaf or hard of hearing. Deaf people who are culturally deaf ASL users are about 500,000 people. And so there are these different groups of deaf and hard of hearing people. In healthcare, insurance, government, they don't identify the needs of deaf people. So we see people who are older, who are losing their hearing because of age, and people within the deaf community who both struggle with some of the same communication barriers. People who are elderly may struggle to get the equipment they need, such as hearing aids. They may not be covered by insurance, and so people may need to pay out of pocket, which is not fair. The average cost of a hearing aid is $2,000 to $7,000. And so think about the cost of a hearing aid compared to, a hearing aid is actually one of the third most expensive things that we may buy: a house, a car, or a hearing aid. So it's important for us to push insurance companies to cover hearing equipment. The communication barriers that patients face also impact their health throughout their lives. People may not receive primary care services because it's inaccessible. Their needs may not be met. And so then they have a higher risk for having more severe health problems that cause them to go to the emergency room instead. Previous studies have found that deaf and hard of hearing people go to the emergency room 17%, at a 17% increased risk. And a large reason for that is barriers in communication, not having an interpreter and not having access to a physician who knows sign language. And so instead, the problem worsens and they end up in the emergency room. If there are communication barriers in the hospital, then that exacerbates the situation. And deaf patients have a 32% greater odds of hospital readmission for those who reported trouble with communicating. And that can include more severe issues such as heart failure. It's also 46% higher healthcare costs for untreated hearing loss compared to those without hearing loss. And these are not great numbers. These are areas that all need to be addressed. We all need to work on finding strategies and solutions to fix these problems within the healthcare systems. So now let me talk a little about survey data and capturing data. For many years, deaf and hard of hearing people have been excluded or not captured by surveys, and that also includes people with disabilities. You may have heard of the National Center for Deaf Health Research. There at NCDHR, they pushed the BRFSA. This was in 2013. The original question was not great. The NCDHR reached out to ask how they identify deaf and hard of hearing people, And the only way that they did that was by asking if people use special equipment, such as a special telephone, which is a terrible question. The question actually asks about a special telephone, a special bed, a cane, or a wheelchair. And so that captures a wide number of people, not just deaf and hard of hearing people. And so the HLAA, another association for people with hearing loss, successfully pushed for this question to be removed and replaced with a better question. So before, there was no way of capturing the number of deaf and hard of hearing people, and no way to see whether they were actually facing different risks, higher risks of heart attack or higher prevalence of smoking. We just didn't know because we weren't capturing that data, because questions about deaf and hard of hearing people were being excluded from surveillance data. Finally, that has improved, but unfortunately, now during the COVID pandemic, of course we know that people are struggling to access services. And the CDC has also run the BRFSA, which I just showed an example question from the original one that was replaced with a better one. That during COVID, they collected phase 1 of the Household Pulse Survey. And there they looked at the impact of COVID on people across the country. In 2020, people's lives were disrupted by COVID. Obviously, it impacted our health, our employment, our socialization in many different ways. And unfortunately, the CDC decided not to include the ACS question that I showed in the previous slide. So again, numbers about deaf and hard of hearing people were excluded from this survey. It wasn't until the next year that they finally put that question back in. So that means that we're missing an entire year of data about how deaf and hard of hearing people did during the COVID pandemic. Now that question is included. 4 of the 6 ACS questions have been included in the recent versions of the survey. But again, we're missing that entire year. And that was 2020 before vaccines were available. And we just don't have any information about the impact on deaf and hard of hearing people. And that's an example of discrimination too. And now in phase 1, we missed that data. In phase 2, it was included. And then in phase 3, we hope that it continues to be included. We need to have data about people who are deaf and hard of hearing and people who are disabled to know how they're doing and to be able to capture data about them. So that's another example of a push that needs to come from all of us researchers. We need to be there at the table. We need to make sure that this doesn't happen again. A third example that I wanted to share, I have a colleague who looked at data related to pregnancy rights. And the NSFG, the National Survey of Family Growth, included some of the ACS questions, which were good. That allows us to look into data on deaf and hard of hearing people. And we found that 16% of that group reported that they had a disability, which is great information to have. And then interviewers met with some of those people to ask more detailed questions. I wanted to contact some of the people, so I contacted the people leading the survey, and they asked about people with disabilities being included. And then they said that it was too small of a group, and so sharing any information about them would lead to confidentiality issues. But 16% is actually fairly large for a survey. It's not that small, and confidentiality wouldn't be an issue if they were to share the data with us. Again, fortunately, that data was collected, but we missed an opportunity to look at pregnancy rights and outcomes of people who were deaf or disabled from within that. We have found that people with disabilities are more likely to be sterilized and are less likely to receive effective contraceptives. For example, Depo-Provera implants or IUDs, such as other long-acting contraceptives. So now let me transition to talking more about healthcare and accessible healthcare. We know that healthcare is often inaccessible for deaf and hard of hearing people. We know from SAMHSA, who looks at mental health and substance abuse use and management in clinics, There's a team led by Dr. James, and soon a publication will be out in the Health Affairs Journal about this. This is one example. If we look at this map, the darker colored states indicate less provision of interpreters in mental health settings. And these numbers are awful. The dark blue means over 60% of clinics did not provide interpreters to deaf and hard of hearing people who used sign language, which means that those mental health services were not accessible. And we knew that in our community already, but we needed this data to prove it. These mental health clinics are not following the ADA or the ACA, the Affordable Care Act. We need to push for change. We also need to push for more signing doctors and signing mental health clinicians. We deaf people need to be there in healthcare provision settings as well. Now in science, and for medical students, we did a survey, a large survey of medical schools, in a study led by Dr. Meeks. And we found, even though the ADA was passed over 30 years ago, only 4.5% of students currently in medical schools identified themselves as having a disability, which is well below the national average. And unfortunately, if we break that down, most of the people with disabilities had psychological or mental health disabilities. Some had learning disabilities, such as ADHD or ADHD. And when we look at the number of deaf and hard of hearing people, from that 4.5%, only 1.3% of that group identified as being deaf or hard of hearing. That means 1 in 2,000 medical students currently have some type of hearing loss or hearing disability or identify as being deaf or hard of hearing, which of course does not correlate to the number of deaf and hard of hearing patients that those physicians will be seeing. We know that research depends on funding from the NIH or the NSF, and it's important that we continue to see representation of grant funding to people with disabilities to do research on people with disabilities, including people who are deaf or hard of hearing. This study, led by Dr. Swainer, looked from 2008 to 2018 and found that unfortunately the percentage of people who have disabilities who submitted grant applications to the NIH, the number actually went down from about 20% to about 13% of principal investigators. And then when we look at the projects that were actually awarded funding, the percent of principal investigators with disabilities went from 11% to 9%. So again, we need to push for change. And we need to increase this pipeline for deaf and hard of hearing scientists to increase the number of deaf and hard of hearing principal investigators. So now let me switch gears a little bit to talk about some strategies to build that pipeline and to support and increase the number of people with disabilities and people who are deaf and hard of hearing in science, in medicine, and in all areas. I'll share some ideas with you based on what I've seen. If we look at DEI, diversity, equity, and inclusion, each of us has a responsibility to look at our company, to look at the place where we work, and to see whether people with disabilities are also included, including people who are deaf or hard of hearing. Unfortunately, the DEI view often does not include people with disabilities, or it may include them almost as an afterthought at the end, or it may use inappropriate language, such as ability, where many disabled people do not like the use of other terminology. So we must include disabled people and people who are deaf or hard of hearing in this language. It's also important that the patient group and the group of physicians treating them looks the same. If there's not identity concordance, that can cause many issues for patients and can lead to worse outcomes. For example, if a group we know that 1 in 4 people have disabilities, we would expect that 1 in 4 physicians would also have disabilities. so that they can share that life experience and physicians can help their patients navigate their life as a disabled person. They may be able to share some strategies or accessibility equipment ideas and better be able to understand their patients' needs. When patients and doctors share a common background, we notice increased trust and confidence, increased communication quality, and increased patient satisfaction. And that impacts their long-term outcomes. And when physicians recommend treatment, patients are more likely to follow those recommendations.
So including people with disabilities or who are deaf and hard of hearing should not be an occasional thing. There needs to be effort in place to make this happen. There was a study from Harvard that was done with several doctors, and unfortunately, about 80% of physicians felt that people with disabilities experienced lower quality of life. And that's pretty unfortunate that doctors have that stigma, because that does influence the patient's options for care. Back in 2020, people were concerned and worried about the rationing of care and whether there were enough providers and enough beds in hospitals and enough ventilators. And that definitely impacted and hurt people who experience disability and people who are deaf and hard of hearing. So that just shows that we need to be part of this team. We need to have colleagues who are deaf or hard of hearing and benefit from their knowledge. We have heard that accessibility all across the United States is unsatisfactory. And unfortunately, again, from a survey, we know that doctors actually thought that patients were responsible for paying for their own accommodations, when in fact it is the physician or the hospital's responsibility to provide them. So there's already this legal responsibility that the information is lacking in these areas. This information must be available in educational settings in order for people to get the appropriate accommodations. So one concept I'd like to touch upon is proactivity. If we stop reacting to the negative, stop being reactionary, and think about the environment we're in and the barriers that exist. For example, if a deaf person were to call to schedule an appointment, the deaf person would need to request an interpreter. But if they were to arrive at the doctor's appointment and there wasn't an interpreter there, the appointment would become awkward, communication would not happen, the patient would become frustrated. And in that moment, it becomes reactionary, where they have to call and find a solution and bring in an interpreter last minute. Whereas if the person was proactive, or the doctor's office was proactive, they would know to ask for specific accommodations that were needed, and all of this care would be much more seamless through proactivity. Now, this slide here is an electronic health record, and there is some control over this. EHR, which is a company or a provider, and so what they did here was to include some proactive information that they wanted to collect from the patient, the staff, and the physicians in order to retain this information in one place. It includes whether they are deaf and hard of hearing, whether there are other disabilities involved, and what kind of accommodations are necessary. Sometimes people require an interpreter or a clear mask or other kinds of accessibility equipment. And so by using this electronic form, it allows patients to input the information that they need. And it does have a measurable impact. This allows people to be more aware of the accommodations that are necessary ahead of time instead of being reactive to an emergency situation. That way, the person can input all their information and whatever accommodations are required can be requested ahead of time. This is something that can and should be used at hospitals across the United States. So this is proactive and captures the information that is necessary in order to provide the accommodations that the patient requires. Next is pipeline programs, such as the programs that RIT has, like Bridges and Bridges to the Doctorate program. Increasing the number of scientists, deaf scientists. Those are just two examples. There is one at Johns Hopkins University that is led by another deaf physician scientist, where they are encouraging applicants to go and train in neuroscience fields. Also, M-Disability is another summer program, internship, where people can come together from all walks of life, whether they're scientists or medical doctors or any other health-related field. They can come and mentor and work with other experts in their field to encourage and increase the number of people who are in the know and provide opportunities for networking. That's one of the main goals of the M-Disability Summer Internship. So also, the amount of NIH-funded programs is fairly low. We would like to encourage more people to apply and encourage people who identify as having a disability to apply. There are research opportunities with the NIH, and so we would encourage everyone to contact them and learn about these additional opportunities. Earcentials 2022 is a conference for that will be happening with AMFL, and we're encouraging people to apply for all of these programs. Confirmed are accessibility options, interpreters, and captioning. So anyone who is interested in any science field should feel free to apply for this online conference. Now, in the last 5 years, it's been actually very impressive with the number of organizations that have come to light that are led by medical students who themselves have disabilities or are in support of encouraging people with disabilities to apply to medical schools and other colleges or universities. And what these organizations do are providing students with support so they no longer feel that isolation. They can develop a network and collaborate with other professionals to successfully enter graduate education. There are national organizations and many medical schools have chapters that can collaborate and sort of influence admissions committees. It does happen, and because of that, we do see the numbers of students with disabilities increasing, which is very exciting for us. There are coalitions, the Stanford Medicine Abilities Coalition, the Alliance, a variety of other groups that can provide support to people with disabilities. There is the Public Health Association that has a subgroup that supports people with disabilities and can help match people who are interested in public health to other people who are doing research on similar issues. So there are opportunities out there, and unfortunately, people just don't know about them. So I would really appreciate the sharing of this information and encouraging people to reach out if they're interested. The Association of Medical Professionals with Hearing Loss, AMFL, has been around for 20 years now, and they are always in support of increasing the numbers of deaf and hard of hearing people in all medical fields. That conference will be coming up in August, just a week from now, so we're looking forward to that. Now, mentorship is key. I can use myself as an example. I helped to develop a network and identify resources and in order to help people overcome those barriers and frustrations to access and opportunity. It's a nice chance for people to get together and share their frustrations or vent. And if anybody has the opportunity to mentor at any point, I would definitely encourage you to do it. And these 4 things here that I have, the keys that are on the slide right now, are extremely helpful to me. I have had mentors who have been able to sit with me and bounce ideas around about accommodations, accessibility, overcoming obstacles. There have been other mentors. Michael Posh Orlow is one who has expertise in communication and has done research about receptive communication, among other things. Dr. Fischella is an expert in disparities relating to race and other types of disparities for deaf and hard of hearing individuals as well. So like I said, there are a lot of networking opportunities, a lot of opportunities to improve a variety of skills and proficiencies. And for me, I see this as an opportunity for deaf and hard of hearing science students to take advantage of something like this and share the information. Now, adjusting technical standards. Many university students may face barriers in their experience, and it's possible that they're using some old-fashioned ways of thinking, for example, organic or functional. I'll use myself as an example. I'm a deaf person, which means I can't hear, and automatically that sometimes means that I'll require special equipment. And so that would be labeled organic. And I would be disqualified. So if a person were to say that they could succeed with an interpreter or with specialized equipment, then they would be accepted and labeled as functional. So by standard, functional is sort of where the admissions committee is looking toward. As long as access is provided, it is functional. Now, often there are complaints about the cost of services, or people are just not knowledgeable. Or what unit or what department is responsible for providing all of this. Now, it's possible that there could be lawsuits involved, but really, it is the responsibility of the hospital or the central agency to make sure that the funding is available and that their budget is flexible enough to allow these accommodations to be provided. And we would encourage all organizations to follow in that standard. Now, there are a lot of other training opportunities out there. The NIH has the Diversity Supplement, which can be added on if there are deaf or hard of hearing postdocs or interns. There are fellowships that can be included in R1 opportunities. These are things that can be added on as additional training opportunities and possibly receive some additional funding in order to provide support for people with disabilities. So deaf and hard of hearing people do have these frustrations and the barriers that they experience, but there are ways to overcome them and strategies to employ, as long as you find the appropriate organization and opportunity. So moving on to these postdoctoral fellowships, there are some for deaf or hard of hearing individuals and people with disabilities. There are some out there. It's just important that you look and find some that are welcoming and acceptable. There are some out there, so I would encourage you to look into the APA disabilities section. Sometimes there are just simple webinars that are rich in information and provide strategies and excellent skills. Ways to manage this could include maybe going to a pre-conference and networking with people, and it's possible that you could meet a future mentor at some of these networking opportunities. So these are opportunities for education as well. Sometimes faculty members and even students don't know whose responsibility it is to make sure that accommodations are provided. And we need to make sure that people know that these are required standards. It's part of the standards is that the curriculum is accessible. And unfortunately, many medical students are experiencing this. And so what needs to happen is that people need to work together to ensure that the environments are inclusive of everybody and that access is provided.
So I can share a couple examples here at the University of Michigan. So here there's a 2-week course, an elective course, for students who are in their 3rd year of medical school, and that allows them the opportunity to shadow with several different disability health experts. So for example, they have the opportunity to go to deaf health conferences with me. They have the opportunity to work with other doctors who specialize in intellectual and developmental disabilities. They have the opportunity to go to vision clinics as well. And so that helps medical students become more familiar, more comfortable, and more confident, and more culturally competent in working with people from different disability groups. There's also an ASL course that was recently created and is offered to first-year medical students, which gives them the opportunity to not only learn a little bit about the language, but also learn about communication in general, how to work with an interpreter, how to work with someone whose language you don't share, and how to set up accommodations. They also learn a little bit about deaf culture, which is extremely valuable and important for them. And that's just one example of some of the opportunities we have here. There are other opportunities at the University of Miami, at University of Rochester, at Ohio State University has some similar opportunities as well. And so I encourage more opportunities like that and more exposure for general medical students about deafness and people with disabilities. We also know that cohorts are powerful, but often they don't include ASL or sign language. So many doctors and researchers are not able to select people who are deaf or hard of hearing or have disabilities. Just last week, we finally passed this ability to look at and identify signers. So now we can compare people who use sign language to people who don't use sign language, and we have this demographic information access. This allows us to better monitor health equity or health inequity. So for example, now we can look at diabetes management within our patients. We can quickly review and do research on where there might be healthcare gaps based on different demographic characteristics of deaf and hard of patients. And so these cohort discovery tools are very important, and it's important to include sign language or the use of ASL in this as well. And then the environment where you work is also very important. It's important for professionals to feel included and invited. It's equally important for patients. If the environment is not accessible to patients, then it's also not accessible to deaf and hard of hearing scientists or doctors or other providers. So the patient's access is important, and once that access is created, then professionals should have the same level of access, scientists, doctors, and other providers. In the Deaf Health Clinic, we have a research checklist, an accessibility checklist, to help us identify where the barriers are based on patient feedback. And that's very helpful for us because there are some things that we overlook. For me as a doctor, if I'm a member of the same group as my patients, I may be able to identify those barriers, but I may not be in the same identity group as my patients, so it's important for me to hear from them. For example, masks during COVID were very difficult for deaf people to deal with, and so we needed to ensure that there were other ways to make it accessible by using clear masks, for example. And now we encourage all of our clinics to change over to using clear masks instead of regular masks. And it's also important that any surveys are offered in ASL. If people are going from door to door and knocking on doors, that may not be accessible for deaf people if they don't have a flashing doorbell. And even for me in my office, if my office doesn't have a flashing doorbell, then it's not accessible for me to know when people are knocking on the door. So accessibility is equally important for both patients and professionals. Of course, we know that COVID impacted our lives in a lot of ways. One of the ways is that now telemedicine is often offered. And patient services and healthcare can be provided from anywhere through remote services, through video phones, or through Zoom. Deaf patients now have the option to contact ASL fluent deaf and hard of hearing doctors. And so we can provide care to deaf patients all across the United States. There are, however, some licensing barriers and some insurance barriers based on the state. But with the technology that we have now, the way that healthcare can be delivered can be improved for deaf and hard of hearing patients. Now, what's important is that we work through government agencies, the licensing boards, the insurance companies, and so on to make sure that we can make this happen. This also includes the opportunity to have CART or live captioning or an additional interpreter. Or even a family medicine physician can call in a specialist as needed. Sometimes there's an issue with the patient not being able to see the interpreter, but there are ways around that. There are ways to bring in an interpreter and ensure that everyone can see each other. And again, these improvements came from people with disabilities and people who are deaf and hard of hearing who pushed for these types of changes. So now, just before I open for questions, I want to end on a positive note and remind everyone that we bring a lot of skills, strategies, coping mechanisms, and ways to address the barriers that we face in our daily lives. We need deaf and hard of hearing people and people with disabilities to be represented in science, on ethics boards, in the IRB, in surveys. We need to be there. We have a lot to contribute, and it's positive for us to be part of it. It's also an opportunity for people to learn about people with disabilities. That's a wonderful opportunity to learn about a different culture and to learn about strategies for access. And improvements in access affect deaf patients in healthcare and also affect better quality of research findings. Representation matters in so many different ways. And it's very important that those of us who benefit from mentorship also give back by continuing to mentor and continuing to develop new opportunities for deaf and hard of hearing people. Deaf and hard of hearing people, community organizations have a lot to contribute too, and we need to form better partnerships with them. Sometimes it is difficult. But don't fight the fight alone. Make sure to collaborate with others, seek help, seek others who will advocate for your needs, and fight for change to improve access and training opportunities for everyone, including deaf and hard of hearing people. We are needed. We have a lot to give. And at this point, I'll open it up for questions.
I've been pondering how much NIH and NSF really are fostering an environment of inclusion by underrepresented groups, especially those with disabilities. I'm really excited to hear about this pipeline, and I'm interested in what my peers who are hearing think about that. So I've asked them what they think the NIH and the NSF and other government agencies, what can they do to create a pipeline for underrepresented people to be more equally represented in terms of race, gender, and disability? And my peer responded and surprised me with the response, which was race and gender feel like they are on a equal playing field already. Disability feels like it's at the bottom of the pile right now. So how do you respond to that statement?
Sure, that's a great point. I think it's important, first of all, that we can never give up the fight. NIH and NSF are huge funding agencies. And we know that it doesn't work to just rely on small organizations. Sorry about that, my dog ran by the computer. NIH and NSF, I would encourage anyone to work with program officers. And luckily, I've noticed that program officers who have experience, some program officers are not very deaf-friendly. Some of them have more of a negative perception in the past. But now I'm noticing that program officers are more understanding of deaf culture and deaf people and more inclusive. And I'm excited to see that change. That doesn't mean that the change is happening everywhere, but I am noticing it more and more these days. Sweener at Johns Hopkins University has also encouraged and pushed for disability representation must be valued, the same as race, ethnicity, and gender representation. All of those different identities should be equally emphasized and equally represented. We often focus more on NIDCD. And I have contacted them to see about disability representation, but also why not the other institutes at NIH? Disability is equally important at each of those different institutes. The institutes on mental health, on substance use and abuse, infectious diseases. Disability is important to be considered everywhere, so we still have a lot of work to do. NIDCHD, I do have a good relationship with them, but there is a lot of work to do with the other institutes still at NIH. And sometimes disabilities are very segmented and siloed. And so that's another part of the problem. There's another funding agency, NIDLR, N-I-D-L-R, that is more disability focused. But unfortunately, their amount of funding is much smaller. But there are other opportunities there as well.
So in terms of your presentation, I think you hit the nail on the head. I think that we do face a significant challenge. There's not adequate representation, and really the idea of making it and build it and they will come, I love that. But one thing that I want to say is that we do have a significant challenge with the gatekeepers. Who are the gatekeepers? They are hearing people who control and screen applicants. They screen in the hiring process. So I'm wondering if you have any ideas or tips for how we can, make change within those gatekeepers. I'm just wondering, in your experience, if you have any tips.
Representation at every level is equally important. The more of us who can be there at the table as gatekeepers will improve that. And medicine over the last 10 years, now for the first time, we have 2 deaf or hard of hearing department chairs in healthcare, chairs of medical departments in healthcare, which is very impressive. And yes, change is slow, but we do need to remember the long-term goals that we have, encouraging role models and bringing in deaf people into those roles. Discrimination does block opportunities, but when people can get into leadership roles, they can help break down some of those barriers. Another thing that I haven't mentioned yet is that I am often focused on post-secondary students or students in medical school. But it's also important to remember that the pipeline starts even earlier, from young kids all the way up into young adults and then college students. It's important that K through 12 students also have good learning opportunities and good education to prepare them and inspire them to further their education. At NIH, sometimes there is internal funding and opportunities to become a reviewer for internal funding, and that gives you, deaf and hard of hearing people, the opportunity to give that feedback. As an NIH reviewer, you have the opportunity to be part of a committee and to review grant applications. And the more reviewers who represent people with disabilities, the more we can affect change there too. There are very few NIH grant reviewers right now who have disabilities, and I've reached out to them to encourage them to solicit more people with disabilities to be reviewers, and to require more disability representation, and to require that committee review includes people who are deaf and hard of hearing or disabled, especially when reviewing grants about people who are deaf or hard of hearing or disabled. But it is a challenge. It's not easy. And I can't see all of you right now, but I do encourage all of you to aim high and become leaders and gatekeepers yourself. But that's a great point, and I completely agree with you.
I'm on a study section for the Agency for Healthcare Research and Quality. We've heard about the NIH a lot today, but people should know that there's another agency that's focused on health quality that's been around for a long time at the government, and that's AHRQ. And an example of what you just described, there was a grant that came in and it was proposing to study an intervention within a large city. And one of the things that they wrote about is they were going to do interviews and surveys, and they were going to do them only with people who spoke English. Like that was the word. They said spoken English in their grant. And being a little more aware about deaf culture, one of my comments was like, well, you're just excluding a whole entire group of people from who don't have spoken English, they're signing, but who would be very valuable to study. So I think your point was really great. Kind of along those lines, you showed a screen where you were proactive. You were talking about being proactive about disability needs. Do you remember that in your presentation? And you showed that that was in the electronic health record. I don't know if you're aware, but electronic health records in the United States, they need to be certified. There's an actual regulatory process that they've been going through ever since 2010 called meaningful use. Do you know if EHRs are required to have that sort of disability questionnaire in the electronic health record? Because that's something I could imagine if that was required, every hospital and clinic in the country would have that as a part of their electronic health record. It would be required for the electronic health records to actually have that as a feature. And I wondered if what you showed was just local to maybe your clinic, but it seems like a really important thing. Do you know?
So to answer your second question relatively quickly, the EHRs, we are working with Epic right now. They're aware of what we're doing here at the University of Michigan. And so we are working with them internally with their technology and IT group to provide feedback on what we've done here at the University of Michigan. We serve only over 40,000 people who use our EHR system as of just a few months ago. And we're encouraging more people to be aware and to share that information with Epic. Our team wants to be able to share what we've done with Epic so that they can share it more widely. In terms of meaningful use, that is very important. Unfortunately, Epic is currently the only company, although they are a very large company, they're the company that we started with, they are the only one, and they don't require disability to be an included field for all medical records, only here at the University of Michigan. And the cohort selection tool that I showed you towards the end of my talk as well, previously was not inclusive of sign language users. They did have other language users, but they didn't have sign language users. And so we required them to include that as well. And I've been noticing that more and more companies are doing that. So for example, the University of Colorado now has a disability field as well. Similarly, they're also using Epic. And we hope that that will be disseminated more broadly. And again, that's using a functional model. So it works here, and we are encouraging other people to use it as well. To answer your first question, thank you for reminding me about AHRQ. There are many different funding sources, and I can give you a few more examples about this too. So I agree that it's important to give opportunities and also to be inclusive. So sometimes it depends on the specific research project as well. Sometimes research projects are narrowly focused, and sometimes research projects are excluding populations that they really shouldn't be. So it's important to have that dialogue with them and to recognize when people are being excluded. And also knowing that, for example, for financial reasons or for other reasons, there is an excuse that's often given in proposals that certain populations are just too hard to access or too hard to find or too expensive to access. And again, that leads to furthering those silos. So here at the University of Michigan, we try to be as inclusive as possible. Although we do highly value the deaf community, we also don't want to ignore people who are hard of hearing or have age-related hearing loss. Again, we know that communication barriers affect everyone and that increasing communication access also benefits everyone.
You talked about the NIH supplement for disability. And I just learned about that because we wrote a grant again for a summer program that was gonna, that we hope, looks like it's going to be funded. And it was in partnership with Gallaudet University for undergraduate students to come and go into research labs and study. And I was a little nervous about that at first because, you know, our university, which is the University of Pittsburgh, basically what it's asking us to do is to commit to making sure we have all the interpreting and accommodation services and then go ask the NIH for money. And they said, yeah, you have to tell us how many students you have who are deaf and hard of hearing. So instead of actually having the infrastructure in place as part of the grant, you kind of have the university pick up the cost and then they're going to get basically reimbursed later. Now, our university was okay with that, but I wonder how many institutions would not be so supportive of that. Have you had any experience with an institution not willing to foot the bill until they get the money back from the NIH? Because that's kind of how the system is set up.
Yes, and again, cost is a barrier. In order to avoid having departmental obligation, it's important to have that central agency or central office that controls the funding. And so whoever is looking for funding for those kinds of services can rely on a central location in the institute, whether it's a hospital or a university, that is responsible for that information. I know it's not a quick fix, but that does seem like something that organizations are turning to, so then people don't need to feel like they're begging or feel guilty for asking for funding to satisfy those needs. Now, I have also heard about the NIH diversity supplement and already having those services coordinated and then receiving the reimbursement for that. Sometimes though, the funding is not reimbursed, Sometimes you can include funding for accommodations in the grant, and sometimes you also need to remove that funding from the budget. And so there are different strategies and different requirements for different organizations, but really if a central agency is controlling the funding for those kinds of accommodations and interpreting services, that is of utmost importance.
Thank you very much, and awesome presentation.